It's my honor to introduce our speaker, Dr. Abraham. She is a professor of anesthesiology and medicine at WashU School of Medicine. She also holds secondary appointments in psychiatry, where she directs the Center for Applied Health Informatics within the Institute for Informatics, Data Science, and Biostatics. Dr. Abraham brings an interdisciplinary background in human factors and biomedical informatics. Her NIH-supported research focuses on advancing the design and implementation of health technologies to improve safety, quality, and equity in healthcare. So today, she will share her insights on making the invisible visible, a topic that's promised not only to inform us, but also to spark the thoughtful discussion among us all. So please join me in giving a welcome to Dr. Abraham. And before she gets started, we kindly ask you to hold questions until the end of the presentation, or you can submit your questions in the chat box at any time, and I will monitor that. Okay, thank you, Dr. Abraham, and the floor is yours.
Thank you. Thank you, Dr. Peng, for the lovely introduction. And also thank you for inviting me for the seminar at Cornell. And I'm excited to walk you through some of the research I've been doing on handoffs and how we actually started using AI as a way to leverage handoff communication. And thank you for all the audience members here. So before I get started, I just want to acknowledge the funding. I don't have any financial disclosures or conflict of interest, but I do have funding that supports some of this work. One is an ARC-R01 that supports the design and implementation of AI for handoffs, and also something called the Big Ideas Program, which is funded through WashU Medicine. So in terms of the outline that I've laid out, and depending on time, we can switch things around. I may go fast in certain spaces, but I'm hoping to cover about post-operative handoffs and also the problems around safety with handoffs, and then talk a little bit about the research approach and methodology we used, and walk you through, like very briefly, a series of studies. So if you had to do something similar at your own institution, you know how to follow this approach to study a particular research area or problem. And then finally, I want to conclude with some AI lifecycle lessons we learned based on our own post-operative handoff work, but broadly on all the AI-related work that I've been doing here at WashU. So to start off, in terms of significance of post-operative handoffs, so what exactly are handoffs and when do they happen? There are over 300 million surgeries that are performed worldwide, and around 50 million is actually performed in the United States. What it means is that there are lots of transfers that happen from the OR to the intensive care unit. And these transfers are really vulnerable to errors and communication failures. So in addition to the physical transfer of the patient, you'll see that there is this communication event that we refer to as handoffs between the OR team, which is the sending team, and the ICU team, which we refer to as the receiving team. And this really is used to as a medium to communicate important information, supporting the functionality of information processing, but also supposed to be used for shared cognition, where the teams can actually communicate their reasoning and thought processes around patient care plan and goals for the patient coming from the OR to the ICU. Resilience is another function for handoff. What it means is really using this forum to identify any errors and recover from these errors during handoffs and bringing in that fresh eye perspective to patient care. And finally, stereotypical narratives. What it means is really you have certain typical narratives that happen for patients that are going into the ICU, but are there deviations or outliers that you want to highlight during these handoff events? So all these four functions are key to high quality handoffs. So to promote safety in handoffs, the Joint Commission has a national safety goal, which is really looking at ways to standardize the approach to communication and also including an opportunity to ask and respond to questions. So you have the receiving team can ask questions that are relevant to the communication itself. So within the post-operative context, because I'm focused on post-operative handoffs for this talk, People have, or hospitals have implemented several handoff standardized tools. There are two key ways. One is having information checklist, as you see in the figure, and these are team handoffs. So really, what exactly are the information pieces that the anesthesia team is responsible for, the surgical team, and the surgical staff in the theater. So there are key pieces of information that needs to be shared. And on the other hand, you have protocols or process-based workflows in place, and they started standardizing that process. So you have exactly idea on like what are the sequence of steps that need to be taking place and who is responsible for what. For instance, if you look at this picture in blue, you'll see the ICU team is waiting for the arrival. They prepare their room, they make sure it is quiet, and then each of these team members talk about what they're going to talk during these handoffs. So there are these checklists as well as protocols that are supporting the handoff process. What we found was that despite all these standardization efforts, there are like handoff errors that still happen due to either failures in communication or not following the process in the first place. And if you look at the literature, you'll see 70% of the medical errors that happen are related to some sort of communication failures. And then when you backtrack, which is done by the Joint Commission, they actually contribute some of these, half of the communication errors, to just these handoff events. So there has been an increased effort to improve patient safety threats during handoffs. And specific to post-operative handoff standardization, you'll see that Anesthesia Patient Safety Foundation is one of those foundations that is very key to handoff safety and other safety measures. So they put out a workshop where they actually wanted to try improving safety in perioperative handoffs and finding ways to get it right and understanding what are those failures despite the standardized goal that is provided, what is happening in hospitals. In addition to that, they also formed a national multi-center handoff collaborative referred to as MHC. It's a national across the United States. And again, their focus is really to get it right or understand what those barriers or failure points are. In my own institution, this is the time I joined WashU. We had started a perioperative handoff task force, again, because our events at our institution were rising in terms of adverse events related to hospital handoffs. So I used this opportunity to start my work in perioperative handoffs and specifically on post-operative handoff safety. So moving out in terms of like what is the way we approach this problem, and also giving you a framework so you can walk through the different studies we did as part of this work. So this is referred to as user-centered design. Many of you already would have heard it. It's sometimes referred to as human-centered design approach, participatory design approach, or other terms people have started using. But really, we use this framework, and the emphasis here is the user is important. The end users are involved in every step. So there are 4 steps in this process. First is, as I mentioned, the end users are important and they are part of the research and also partners with us in understanding the process. So the first step is contextual inquiry. What it really means is going into understanding what the problem is, what is the context in which the problem is happening, and getting some assessment on what the needs are. The next step is design ideation, which is really gathering those design requirements. So if you need a new tool, we try to use this step to actually ideate or come up with ideas and requirements for the design of the intervention or new tool. The next step is really looking at prototype testing. So how do you build these prototypes? And these could be low fidelity, paper-based, PowerPoint-based prototypes or initial frameworks. And then how do you refine it and test it? And the last step in this process is then actually developing our intervention and implementing it and evaluating it. So as you can see in this figure, these different steps are extremely iterative. It's not like once you're done, it's a linear process. You actually have to go back and forth depending on new requirements or changes that happen to your intervention. So I'm going to use this framework to summarize our work that we have been doing as part of this research, and I'll go through the different steps and our studies that we have conducted. So UCD step one, as I mentioned earlier, is really looking at what are the problems, and we were interested in what are some of the post-operative handoff standardization failures at our own institution, and then also understand what are the contributors to these challenges. So as part of that, we conducted a study, and I'm going to briefly show you what we use here, or what people have been using here. The way we have standardized our process in at WashU and BJ, our hospitals, which is the Barnes Jewish Hospital, is really using a bundle. So it does have a process-based protocol in addition to a checklist. So the protocol is that there's the pre-handoff preparation phase that is shown in this figure, where the anesthesiology teams prepare. They call the charge nurse for the ICU and then prepare for handing off or transferring the patient. Once they are on the unit, in the ICU unit, there's a process in how these different team members communicate information. So as you can see, the circulating nurse is the first one to go with their report, followed by the surgeon and then the anesthesiologist. Something that is unique to our hospital here is that we have an eICU, or a telemedicine ICU, that actually participates in these handoffs. So they do listen in. If there's a video audio button, they do zoom into the room and actually listen and provide additional information as needed. And the checklist that we have implemented here is really a laminated checklist at the patient's bedside. And you can see anesthesia is responsible for transferring all that information or communicating, and then you have surgery team talking about the other information pieces. So this is how our hospital here implemented the standardized approach to post-operative handoffs. So we conducted a qualitative study, really shadowing our clinicians here to understand what are those standardization failures that happened. And we identified 4 different phases, and we identified failures in each. So the first one is pre-handoff preparation. Not every time those calls go out to our nurses in the ICU. So there's sometimes delays and there's poor coordination of patient transfer. So sometimes the patient is transferred without a lot of heads up, and there's no time for even preparing for handoffs. The next is actually transferring the patient and setup. Really, it is at the patient's bedside in the ICU, so the space is very limited. And when you have the OR team and the ICU team, there's very limited opportunity to use EHR or even bring in any computer in the room. And then there are other related issues, which is just getting the team together and making sure it is quiet so that they can actually start the verbal communication event. So for the verbal handoff, as I mentioned, because it is cramped and because sometimes our surgical team members provide their handoff and immediately leave, there's never this approach of having a team-based handoff. And most often we found that people were not paying attention to some of those information elements. There were omitted information. We did identify using an audit that there were inaccuracies in what was being transferred. And as I mentioned earlier, there is no access to an EHR or checklist to actually provide or transfer that specific information. And lastly, post-handoff care is after the OR team leaves. We found that because these handoffs are really constrained in terms of time, we found there's limited opportunity for questions and even receiving any information. The OR team usually do not provide their contact information, so there's no callbacks to the OR that can happen. So ICU team is limited in terms of how much information they have, and there is no discussion around post-transfer care goals or plans for care. So this was based on around 100 handoffs that we were able to study. In addition to this, we actually did other interviews and checked other ways of auditing the process. So what we found was post-operative handoffs are a complex process. What it means is really there are interdependent pieces or elements in the process, and it is non-linear in terms of there are no sequence of steps that you need to actually follow. Sometimes it's so dynamic, things happen. They don't have time to give a heads up because sometimes there are emergent surgeries and there may not be even beds available in the ICU. So things happen in a very different way. And you have to adapt to new behaviors and emergencies. The outcomes are uncertain or unpredictable in some patient cases. So if there are risks or complications and things and so forth, usually patients do not end up in the ICU immediately. They go back to the OR for additional monitoring or sent to the PACU for some more monitoring before they're actually sent to the ICU. And then we saw that there's diverse teams and expertise. As I showed you earlier, you have the ICU team, you have the surgical team who are surgeons, and then you have the anesthesiologist, and you have nurses and critical care attendings and fellows. So there's a lot of complexity in this process, and we feel some of these complexities can be addressed using AI or AI-based technologies. So in step 2, we really focused on, okay, if we have to design something, we did not want to go back and start from scratch. So we wanted to look at what have other people done in terms of interventions. Are there interventions in place that are effective? So we did a systematic review as part of this work to start off and then figure out what can be done at our institution. So as part of this work, based on our systematic review, we found, and these are the functions I showed you earlier in terms of information processing, shared cognition or mental models, stereotypical narratives, and resilience. And we found that there were only 5 interventions that had very implicit functions or implicit ways to support all functions. So there's definitely this gap in the standardized checklist or standardized protocols and supporting functions. And then we looked at whether it actually improved outcomes. And what we found was, I'm sorry that the figure there is small, but based on our forest plots and meta-analysis, we found that handoffs, like standardized tools, do improve technical errors or gaps in patient transfer process. It helps in improving information quality. So you have information sharing score improved, information omissions improved, and time to analgesia dosing also improved. So there's some improvement that we did find using these standardized tools. But we also found that there was no change, or there were only partial improvements in duration, ventilator time, and so forth. And then when we actually followed these tools and the studies, we found that most folks actually were compliant or using these tools only for a limited period of time. Folks who did studies after 6 months found that there was no sustainability of the standardized process, and which could be attributed to a number of reasons. And we found that outcomes actually deteriorated over time. So this is a paper we published relating to this topic in terms of like, maybe we should move beyond standardized checklists and protocols and move into a more flexible approach, given that there are these issues around complying to standardized checklists, maybe because of its rigid format. There is a limited support or lack of support for collaboration and the different functions that are important for handoffs. And we also don't have a lot of research or literature or evidence that they can help with longitudinal outcomes. So we moved on to our next step, which was really, okay, so now that we have done this review, we gained some insights. The next step is really understanding what our users or our end users at our institution want with regards to post-operative handoff communication and transition interventions. So we did this study where we used scenarios with our users and got some ideas on what they would like to see. So we use a method in user-centered design approach, which is called card sorting. It's really giving a bunch of elements and asking our clinicians and participants to sort these elements and group them into must-haves or maybes or really irrelevant information. So we started off with this process, and we did it in person, as well as we did it online to see how people move things around. And we were able to quickly identify what are those core elements and what are those flexible elements or maybe elements depending on the type of ICU patient. So these are some high-level findings in terms of like that stood out to us. And just so that everybody knows, we didn't go in with the idea that we needed AI. It happened to be as part of the study that people were talking about patient risks and how they wanted this flexible report that can help with the personalized handoff communication. So here you'll see that clinicians prefer to have a flexible checklist that is more tailored to both the patient and surgery characteristics. And as you can see in the quotes here, they want to see what are those harder to find details as opposed to just having a standardized checklist with all the information. So really looking at what are those outliers that they need to focus on during these communication. In addition to that, our clinicians also said they wanted to see what those things are in terms of risks for the patients and what should they care about rather than going through a summary or synthesis of information. So we did notice that people did want their handoff communication or report or tool to be more personalized to the patient, specific patient characteristics and surgical characteristics. The next thing that they also emphasized was it would be great if they could not just only see the risk, but also see what are those contributing factors. So as you can see in the first quote, you see why a patient is at risk. So they wanted to see why is a patient at elevated risk for mortality and comparing that patient to other patients. In addition to that, they also want to see what are those modifiable risk factors. And this came up several times in our focus groups and interviews in terms of it's important to see not just all the risk factors, but also see what they can act upon. So if you say the patient is at risk for mortality given their age, there's nothing much they can do with the age, but if you're able to show other factors, for instance, smoking and so forth, there are things that they can mitigate using that information. So really understanding what they should do with the risk factors and how can they mitigate those risks and having those strategies in place. The other piece was, again, I'm going through the protocol now. So as I mentioned, the protocol is the process-based piece. One of the things that they mentioned during our interviews was that they want to have an established role for EICU clinicians. Even though the EICU clinicians did log in and listen to the handoff, they really did not have a specific turn in the process. So they wanted to use the EICU to police the handoff process and identify those errors and support resilience and help with the handoff overall. So we identified these as our design requirements. And as far as our next step in the process was then to look back at, because we got these ideas around AI and how to use AI, we really went back to the literature to see if there are any studies looking at using handoffs or using AI for handoffs. And to our surprise, we did not find a lot of studies. The most we found was smart RFID tags for supporting data transfer, but we really did not see any AI-based technology. So we understood that the AI definitely has a potential to enhance handoffs, especially looking at risk predictions and prioritizing patient information. And it can also help with just improving the handoff duration and workload when it comes to preparation for handoffs. So we did our next study with nurses and looking at post-operative handoffs, and where we found that people did agree and did like the idea of augmenting the current standardized tools with AI risk estimates. And what they found was that it would be useful for not just communicating, but also asking the right questions during these handoffs. So you can actually plan for the patient's reevaluation if something is at risk, or plan for anticipatory management and guidance. So we did find some information around the importance of using these tools as part of handoffs. So moving forward, our next step was then to actually predict these risks. This was a new territory for us. So we started looking at post-operative complications. We selected in the next slide, I'll show you what those complications are that are important for ICU patients. And we started developing this machine learning models to actually predict those risks and also identify what those risk features are that contribute to those risks. So for this, the first step is to actually get the data, which is definitely a very, very difficult and challenging process. So we used both pre-operative data, medical history, and so forth. And in addition to intraoperative data is data or variables that are available in the OR setting to predict post-operative complications. So the 5 complications that we were interested in, and this was based on our studies with both ICU and OR teams, where acute kidney injury, delirium, DVT, pulmonary embolism, and pneumonia. And based on our initial and modeling exercises, we found that we were able to get high performance with our machine learning models. And we actually evaluated some of our performance metrics with our clinicians on board and found that it was actually producing information in terms of that is useful features, and we were able to move on to the next step. So the next step was then really looking at, okay, now that we have our models and we know what we want to show, is really looking at how do we build these models and refine a prototype and then present it to our clinicians for evaluation. So as part of this, we did 2 studies. The first one is really looking at low fidelity prototyping, which is really based on our PowerPoint presentations. We use scenarios for our clinicians, and they went through a patient scenario, and then they would give us an evaluation on whether they trust our machine learning predictions, and also the usability piece, which is really the format, the structure, the organization, and so forth. So what we found in terms of initial feedback was tables and graphs are useful for risk predictions. As you can see, we offered both to them, and we had a narrative format, and they chose these 2 formats as being valuable. And then we also asked them about information, understanding whether clinicians would understand. And some of our clinicians mentioned that it would be useful to have additional pop-up information where people can supplement if they don't understand what that graph means and what that error bar is. We could use that as a way to provide additional information around the machine learning piece itself. In terms of the content itself, people did feel, or our clinicians had a lot of discussion and agreement around having a confidence interval or an odds ratio, or making sure we are also providing the accuracy for predictions and not just the prediction itself. And there were consensus around the threshold. So you'll see those bars there in the graph, which were our risk thresholds that we arbitrarily placed at the time of our exercise. And although people did believe thresholds are important, we did not have any consensus on what the threshold should look like, mainly because it is hard. First, there are 5 complications, and it's hard based on just clinical evidence to pick those thresholds, because those thresholds are very, very, very low for high-risk patients. So if we did pick low thresholds, all our patients would actually end up being high risk at all times. So there was no consensus around that as well. In terms of our format, we provided 2-3 formats and like how they want to see the risk features. And we found that people did like increasing risk and like decreasing risk. So on one side, you can see what are the protective factors to risk. And then on the other side, you see what are the factors or features that contribute to the risk. Some of our clinicians also preferred pre-op, intra-op, so you can actually see what are those variables even before surgery that are contributing to the risks. And intraoperatively, like what are things that contributed to risk. So we did provide both formats, and we had another format which clinicians did not want to see. Finally, our last ask was whether they wanted to see relative risk compared to average patient population. And we found that our clinicians really wanted to compare that specific patient to all the patients with similar surgery and see how much this patient is deviating from the patient population. So we had some insights around like how to show it and what would it look like. And what it helped them is, as this quote here shows, is really understanding like what are those things that need to be done to escalate certain preventive measures so that you can actually create those risk mitigation strategies even before the risk happened in the ICU setting. So our prototype, as a result of our first exercise, was something like this. It's very simple. We used red and green because our clinicians did like using the traffic light signal colors. and to show what those risks are. And then when you click on each of those risks, you can get into the secondary display where it actually gives you options to toggle between the different grouping formats. And those are risk features and clinicians were able to understand. So this was our, again, not high fidelity yet, but our initial prototype based on our discussions and study that we did with our clinicians. And the next step was actually creating this high fidelity prototype. Again, not it's something external. It's just a website. We created something there, which is hosted on our intranet, and it is secure for our clinicians. So they would have to log in and do this usability evaluation as part of this study. So our next step was to create this prototype and go through a number of real-time cases with our clinicians. So we had around 15 clinicians evaluate this, and they did a cognitive walkthrough. And the goal here is, one, to evaluate the usability of the machine learning augmented risk report, and two is also to evaluate the feasibility of actually the workflow in terms of accessing it and other issues around the machine learning output itself. So we did some refinements as a result of this study. And these are some barriers or benefits and facilitators to the report based on our study. People did feel that the report was useful for supporting the different handoff functions that I mentioned earlier, especially in particular in supporting anticipatory guidance. So they can see if a patient is at risk for delirium, and if they view their risk features, they can actually implement a risk mitigation strategy early rather than later. So clinicians appreciated that information as part of the care planning in the ICU. The other piece that was highlighted, which was not the intention for this tool, was the education piece. A lot of our clinicians felt that this information can be used for residents and junior trainees, because seeing the risk features provide additional information around, like, why is a patient at risk for a particular complication. So they really felt it's not just a clinical decision support or a clinical tool, but it is actually useful for educating on those risk features. The other piece in terms of facilitators, people did like the association between contributing features and risk complications. So it was easy for them to understand the features. And they also liked the color coordination and usability piece with regards to how severity was ranked in our primary display. However, we did have usability questions, and one of the questionnaires we actually administered at the end of our session is referred to as post-study system usability questionnaire. We did, so lower scores, we conducted these studies in phases. Lower scores means better usability, and you will see that we did not do a lot of improvement, or actually it was worse when it comes to the risk report usefulness. And part of the challenge is people didn't know when exactly we would be using this report. People had our clinicians had ideas around using this report during surgery because it is useful information if it was live, or using it even preoperatively, so you can actually, if you can see those risks preoperatively, you can actually plan for the surgery better, or not even have the surgery in the first place. So there was some confusion on when exactly this report is useful. And some of the usability challenges, other challenges where if you saw our risk features, sometimes the bar length was not actually corresponding to the number that we provided as risk feature contribution. So there were confusions around that. And also some of the SHAP values, for those of you who have done explanations, you'll see some of the SHAP values or technical information that we provided really didn't make sense from a clinical standpoint. So there was a lot of confusion around all of those values and scores that we provided when we were literally taking it from the machine learning model. And other challenges that were highlighted were related to clinical intuition discrepancies from the machine learning model. So sometimes clinicians expected to see certain features and they did not see it in our output. So that created confusion. And there were other spurious features that actually came into our machine learning model output that was actually surprising to our clinicians. So there's always this balance between what clinicians are expecting to see versus what our machine learning model actually provided. So, and part of the challenge is because we had over 300 features that went into our model. So some of those features were actually very irrelevant to the clinician. And the other thing that they mentioned was based on the features itself, it was very hard for them to tell a story in terms of like what exactly is the machine learning model trying to say. So we did scope it down after the study, but there were some confusions around how these things were related, what is related to what, and just surprises in our features itself. And we also found that there were other unintended consequences. Obviously, there's a lot of issues related to interpretation itself. But there were other things that we picked up in terms of our clinicians worrying about covering themselves legally, because sometimes, let's say, the machine learning model said that the patient is at risk, but you as a clinician believe the patient is not at risk, and they're worried about actually adding more work to their workflow because now they have to go and write in notes as to why they feel that the patient is not at risk. So there's this additional information from a legal standpoint that they have to add as part of this if machine learning was being used as part of handoffs. And the other thing is it could create bias. Sometimes there could be, and everybody knows this in terms of not just the bias in the data set, but bias in a clinician in terms of believing or trusting or over relying on this, on the machine learning output and making decisions based on that, or using that as a way to get an ICU bed, for instance, and so forth. So there was a lot of information around how this can actually create unintended consequences for ICU and OR clinicians. So we did create several prototypes based on our faces. The first one is in terms of our primary display. This was the second iteration of our primary display. And then we ended up doing something like this, where we actually show them the thresholds and also show them the risk summary and provide more information about our thresholds. In terms of our secondary display, which is our risk features, we started off with this prototype in our first phase, and then we ended with something very more simple. And it also provides risk mitigation strategies for clinicians. And as you can see, the arrows, red and green, show which are the features that are protective and which are the features that are actually increasing risk. So we did make some changes, and we did identify a few more issues in phase 3 of our study with regards to some of those values, and we worked on those as well. So moving on, so in terms of, this was the risk report, and the next piece is actually integrating our risk report for implementation into Epic. So we are currently, and this is something that is happening right now, we are in step 4, where we are integrating, and given that this is part of a research project or process, it is through Smart on Fire. It's implemented within the Epic handoff report. And this is the work that I've been doing with the Multi-Center Handoff Collaborative and Epic directly. And so this is how our current handoff report looks like in Epic. And if you see, there's a link at the bottom, because this is as part of research, where we actually link them out to our site, which has this information on the machine learning risk report itself. So for clinicians who are interested, they could click on that and get this additional information as needed. So the other piece to our work is also looking at the process. As I mentioned, sorry about the typo, but as I mentioned earlier, it's not just the tool itself. We are also interested in the post-operative handoff protocol. So at the bottom, you'll see the eICU team. We changed the process. We gave them an additional role. And really, essentially, what we're using them is, rather than implementing or integrating these machine learning risk output directly at the clinician's hands, hands. We are using the eICU team as our additional layer of safety so that they could be the ones evaluating our risks and complications and provide additional guidance on anticipatory management for the rest of the team. So we do have them as a layer of safety as part of this process. And next steps are really, we're doing a trial as part of this work, given that it is funded through a research project, and we want to finalize a report and workflow as part of it. I know I have only a few minutes left, but I want to get through why we have made this process into an AI-powered post-operative handoff. So really, it is moving from rigid standardization into flexible standardized approach, and we're using these different processes, both elevating or harnessing AI, but also harnessing telemedicine as part of the process. So we are ensuring safety in this work. I don't have time to go through all of this, but some of the lessons we learned, and this is not new to people here, I guess, but really, if you look at the AI model lifecycle, you'll see that there are different steps. And first is problem identification, requirement assessment, developing the model, doing the validation retrospectively, and then doing the prospective validation. Then the model deployment, integrating into EHR and clinical workflow, and then how do you maintain and monitor it? And what we found was there are several barriers based on our work and other research studies that I'm conducting here that are important for each of these steps. And I think I just want to, given the lack of time, I want to emphasize that the problem identification, the retrospective validation, and the development are the easy parts of the project. I think the hard parts start with user evaluation and actually the integration of AI models into the workflow. And here are some challenges that I've highlighted in terms of human factors, challenges that we have to pay attention to, technical implementation and usability challenges. And also moving on, once we have these models, like how do you integrate it? You will see that AI tools, especially if you're looking at generative AI that's coming out, those tools evolve, clinicians evolve, their performance evolves, how they interact with the EHRs evolve. So how do you actually come up with an evaluation plan and understand like what are those measures that you need to follow up on? So that has been our biggest challenge, and we're working through this. And the last piece is like, how do you maintain these systems in place? We do have a lot of challenges or a lot of guidance that is needed in terms of how do you monitor the maintenance, making sure you're monitoring for drifts in performance, model development, and so forth, but also this whole process of continuous adaptation. With that, I will stop here, given that we have only 10 more minutes left. But there are, for those who are interested, you'll see the biggest problem as who are interested in reading this Gen AI divide, you'll see that most of our pilot projects don't go beyond pilots. They're not actually implemented. So researched models are stop at the pilot stage, given those challenges with implementation and integration with EHRs. And vendor models, unfortunately, on the other hand, do get implemented without much evidence. So there is this, I would recommend folks on this call to take a read of this JAMA Health Summit report on AI, which actually walks through some of those challenges and also some of the strategies to improve evaluation and implementation and dissemination. And with that, I'll stop. So for those who have questions, I'm happy to take questions at this time.
Thank you. The floor is now open for questions. Anyone? If you have any questions, feel free to unmute yourself. I'm also interested in continually monitoring the machine learning based methods, particularly now we have the LLM based chatbot based applications. So it seems more important to continually evaluate the applications after deployment. So I know you talk a little bit about that at the end, but can you elaborate more about what level of evidence should be required before we we can build the trust
Ah,
between the clinicians and the AI?
yes, that is a very difficult question. So one of the lessons we learned in terms of trust, because you brought up about trust, is showing features that don't make sense to them are definitely detrimental to patients' trust in the model. If they see one risk feature or one piece of information that is misaligned with their reasoning process, then they just don't trust the whole thing. So I think that's been a big challenge for us. In terms of what is required uh, for ensuring ongoing evaluation and making sure we are adapting our system. I think it's still an open problem. I don't think we have various reports and various guidelines, but
Mhm.
we really don't know what are those metrics, especially for locally, we are doing great work. We're able to do things, but I think across like on a national scale across sites, if the models that we have developed are generalizable, let's say to Cornell, those are things that we still don't have those evaluation metrics in place. And we don't have, most of our evaluation metrics are very task dependent, and very context dependent and not easily generalizable. And I think the first thing would be to come up with those generalizable metrics of evaluations. And maybe implementation science is a field that has a lot of insights and frameworks on those outcomes that can be used across institutions for AI technologies and digital health in general. But um, there is this a very beautiful paper on like how you have to integrate implementation as part of your evaluation and not just think about accuracy metrics or model performance metrics, but how do you also look at implementation of strategies and implementation outcomes. So there's a lot of work. It's just that nobody has done it. Like it is, if you go and if you Google the number of RCTs, it's like I think last week there were 600 ongoing RCTs on AI tools. But
Mhm.
after that, I think it's the translation. Like, how do you actually get it to bedside? And I think it's more than a technical problem. It's more of a workflow and I don't even know. It's a lot of moving parts. So that's why if you look, there are reports on like AI is like a complex adaptive system and
Yeah,
how do you develop those measures to evaluate those. And yeah, it's an open question.
yeah, I totally agree. And
Yeah.
since you mentioned, I'm not sure who is asking, but go ahead. No? Okay. Since you mentioned about the RCT, I also concerned that whether or study or evaluation keep pace with the
Yeah.
rapidly evolving AI techniques. So what's your thoughts about that?
Yeah, I don't think, even including my own study, I was funded maybe 3 years ago, and I'm still struggling because the technology is outpacing
Uh-huh, yeah,
the stud. Like I still struggle with the model enhancements that we have done and so forth. So I think it is a very hard, it is hard to keep up with. On one hand, you have the AI models that are
uh,
improving. On the other hand, you have to find the best way to do a rigorous study. So I think
right,
moving away from randomized trials and maybe doing more um, actual pragmatic trials and having innovative design and measures would be the approach. Because it's not just the AI, it's also the clinicians. We are in an academic medical center. I can train my clinicians who are doing the study, but then the actual people who are using it may not be the people who have been trained. And there's a lot of research on like how clinicians need to be trained. There are like people have developed competencies around AI for clinicians, but I think it's even that needs to keep updated because our technologies are really advancing at such a rapid pace that now I don't even think ML machine learning in itself is interesting anymore, given the generative AI. So now I'm trying to switch gears and see, okay, are there other things that can be done rather than having a tool that provides information? Can people actually ask questions from a chatbot that is a handoff chatbot. So I think it is hard to keep up with current technology advancements, and also we just need to have better ways to evaluate it rather than following the gold standard of RCTs, because that's not how clinical environments work. Because
Yeah.
it's all adapting. It's the
Mhm.
context is also changing. So
Right.
and in an RCT, everything is so controlled for the study that you may get great results, and that's what we have found several RCTs that have great results, but not after you're done with the study, those improvements do not sustain. So
Right.
yeah,
Right. Yeah.
yeah,
Okay.
lots of
Mhm.
questions, but I think I don't have the answer.
Yeah, lots of questions, but also lots of opportunities
Yes,
to
yes, definitely. Yeah,
Mhm.
definitely.
Okay, we have one more. I think we have time for one more question. So what's from the audience? What challenges have you encountered for when introducing those tools into practice?
Oh, great question. I think the biggest challenge is like, why do you need another tool, right? Like
Hmm.
clinicians already have so many tools and so many decision support systems. So just convincing people or getting their buy-in into what will this additional insight or additional tool provide is very, very challenging. So I think, and that's why the first step in terms of the model lifecycle, you'll see making the case for a clinical value is important, because I don't think AI should be the solution for every problem. It is trying to choose the right problems for AI is important. And then one of the ways we have addressed this question is showing them anecdotes where it has helped. As I mentioned earlier, we have had several events in our own hospital, which actually got me motivated to do this work. Is there were sentinel and adverse events. So just showing them evidence on like how this additional insight would have helped with the patient safety. So showing that is definitely important. So I think buy-in is the number one challenge, because once you have this information, especially clinicians, the way they interpret it is, once you give them the information, they cannot unsee it. Like they have to act upon it. And the question is, how do you want them to act upon it? Do they completely ignore it if they feel that machine learning output is wrong, or do you still want them to document something as to why it is wrong? So we are this trying to balance the additional workload on clinicians, but making sure that they have this information also at if they want it. Obviously, we are not creating hard stops based on this information. We're just giving them this additional insights. And our hope is that this will help with our, once we do the trial, we'll get more insights on whether this is useful. So we don't know. This is just the process of getting to this point, which took us 3 years,
Yeah.
unfortunately.
Yeah. Yeah. I think we are right on time. Thank you again for the very insightful presentation. And thank you to everyone for joining us today. This concludes today's CTSA seminar, and we look forward to seeing you at our next session. Have a great rest of your day. Thank you.
Thank you. Thank you all. Thank you. Appreciate it. Bye-bye.
Bye.